We discussed the management of this broad-based multi-lobulated ACOM aneurysm. We note that there is a superiorly and posteriorly pointing lobule and a nubbing close to the base of the aneurysm in the artery. This is the AP projection and the working projection of the aneurysm in both the AP and the lateral planes. The stent microcatheter, here an O-7 microcatheter, was taken into the left A2 ACA, following which the aneurysm sac was catheterized with the O-7 microcatheter. Few loops of the coil are deployed into the sac prior to deployment of the stent. This measure helps prevent aneurysmal rupture due to inadvertent forward movement of the catheter. Notice the stent being deployed across the neck of the aneurysm. Once the stent is deployed across the neck, a forward push is given to provide an adequate shelf for the coils. Coils were then progressively deployed into the sac, and you note obliteration of the superior lobule. In this roadmap, you notice the coil entering the posterior lobule of the aneurysm. We were able to achieve coil packing into both the superior and the posterior lobule. Once adequate coil occlusion is achieved, the microcatheter is removed, following which the rest of the stent is deployed. Initial post-procedure angiography showed there was a clot in the ACOM region and along the left and right A2 ACAs. The patient was kept on Tirofiban infusion, and few hours later a repeat angiography showed there was decreased flow in the right A2 ACA. Intra-arterial meldrenone was administered and Tirofiban infusion was continued. She had an Ommaya inserted in view of a borderline dilated ventricle. In order to improve the cerebral perfusion pressure, a continuous drainage was performed. The final angiogram showed significant resolution of the clot.